Welcome everyone to our ECDC's Modeling Perspective speaker series, where we cover topics related to infectious disease modeling, all the way from technical aspects of the discipline to the application of models to support decision making in public health. My name is Jose Canevari. I'll be moderating today's session. I'm joining this call from ECDC's offices here in Solna, Sweden. We have a lovely sunny day today. Please feel free to say hi on the chat. Tell us where you're joining us from. Today, we are in for a treat because we have a very, very special guest. We are joined by Dr. Andrea Ammon, Director of ECDC. Andrea, very warm welcome to the Modeling Perspective speaker series. We already tested microphones and everything, so we should be all right. Andrea has had a long and very successful career in the field of public health. She was the head of the Department of Infectious Disease Epidemiology at the Robert Koch Institute in Berlin until 2005, when she joined ECDC, so the very early days of this organization. She played a lead role in developing and enhancing surveillance systems in Europe, taking them to 21st century standards. She became deputy director in 2011 and director in 2015, if I'm right, 2 years acting and then confirmed in that role in 2017. So Andrea was at the helm when COVID-19 hit, which must have been a very, very challenging position to be in, but one she had been preparing for a long time. The title of today's talk is Mathematical Models for Advice and Decision Making During the COVID-19 Pandemic. One more thing I should add is that Andrea is, sadly for us, retiring from ECDC soon. So don't miss this opportunity to ask questions. You can post your questions in the chat and we will read them out loud for you after the talk, or use the hand up button on the top of your screen. We'll give you the microphone. We'll now hear Andrea speak for about 25 minutes or so. It doesn't have to be exact. And afterwards, we have time for questions and discussion. We do aim to by 10 to 4 p.m. European time. Right, so without further ado, let's open the stage for Andrea now. Please take it away.
Yeah, thank you so much, Jose, and good afternoon to all colleagues. I hope I can meet all the expectations that Jose has now built so high. And I want to say up front, which you probably have already gathered, that I am not a producer of models. I'm a user of models. So, and whatever I say from this perspective. I see whether my presentation sharing skills are still up for the. So, and now you tell me this doesn't work, right? You see two slides.
We're seeing 2 slides at the moment.
And now?
Yeah, now you're on presentation mode.
Good.
Perfect.
So, Jose has already alluded that I was director during the pandemic, and that was basically where mathematical modeling got a huge boost definitely in our institution, but I think also in general. And so I want to go back for the beginning to the question, why do we do why do we do mathematical modeling? And I have two areas that were very important for us. One was the projection of developments. So how is the development of the pandemic in the next period? And the demands were very varying. Some said, well, yeah, in the next 4 weeks, but that was usually way too short for them. And sometimes it was then the 6 months, the next year, or even in 2 years from now. So was then the period where we also said, well, we can actually reliably only do projections for the short term. If we want to go with the models in the longer term, we have to do scenarios. And I will come back to this. But one big area was also that the models were used for aiding decision making in terms of tactical decisions, which measures should be taken, which population should they be used for, how long, and any combination thereof. But also now, increasingly, that we're out of the pandemic, it's also for strategic decisions in terms of medical countermeasure planning, kind of stockpiling, shortages, and in general also preparedness questions. And the forecasting models were then also used for these kind of topics as well. Now, before I go into a bit more into detail to this, I'll say a bit about the development of modeling in our organization, because we had a modeler quite early on, a single person that had a hard time to establish modeling as an integral part of our work. For many reasons. We were in the startup, we didn't have good data of our own, we didn't have time to develop the right questions, the demand was not as consistent as it is now, and so forth. So after a few years, the colleague left. And in 2017, we said, well, yeah, now we have a better situation. We could have a modeler again. And we recruited again one person. And I have seen Helen in the audience. So she was the one that we actually started the pandemic with. And then it became quickly clear that one person cannot manage this at all. And then that was sort of then the starting point for building a team. And I think now you're 6, which I think is still a small group. But I think compared to 1, it's a considerable progress. And we will see how this can continue. Now, going first to the projections. The question was, how will the epidemiology of COVID-19 develop in the short term? And this question was asked right in the beginning when we had, and that there you see the combination of this forecasting with the decision-making question. When the Commissioner for Health met on a weekly basis with medical companies, so pharmaceutical, but also medical device producing companies. Because if you think back in the first half of 2020, when the cases started piling up in the ICU, I mean, a lot of medication that is routinely used in intensive care units was just not there. And then how much should they look for? And they were looking to us for the numbers. And it was very difficult, impossible to tell them. Well, we could tell them for the next 4 weeks, quite relatively reliably, but not for the half year that they were looking for. And at that time, we didn't even know that there would be variants. So then it was even more difficult. So, but here, it relatively soon, we also recognized that we were not the only ones having these kind of projections. There were other groups in many countries as well. And it turned out that not talking to them is not a good idea, because we got not angry, but really critical questions from them, why we have these figures, they have different figures, and we can't contradict each other. So the idea of having a hub where these groups actually can talk to each other, but also where the individual models can be assembled in combined, so as to minimize the bias that each model more or less had, came relatively early. So, and there was the foundation for this forecast hub that we had during the COVID-19 pandemic with European, but also with teams from outside of Europe. And that was a group that really looked at, you see it in this, you see it here on the like 4 to 6 week period. But then there was a question, but then especially after the Alpha and Delta variants came up, what is if a new variant is coming? And then later on, when we had the vaccine, the different vaccine uptake, the waning of the immunity, and so forth. So here were questions then in a longer period in advance, they wanted us to answer, and this cannot be done with a single projection. There you have to have scenarios. So then this was maybe it was the same people, but the group was named differently. So it was a scenario hub that really developed these different scenarios. Now, since last year, we're out of the pandemic, and we have integrated COVID-19 with other respiratory diseases. And so it's only a logical development that also the hub is now dealing with the other respiratory diseases. Because while during the pandemic, it was COVID singularly, because there were no other respiratory infections due to the non-pharmaceutical measures, there was very little to non-circulation of influenza or respiratory syncytial virus. But now they are, of course, happily co-circulating, and it is important for hospitals and health facility managers to know what is it, how does it look, because there are countermeasures available, but they only work specifically, so it is relevant. And there will be also scenario-based projections for the respiratory diseases. All respiratory diseases later on. Now, what I say here, when I look back, it was not so easy to convey this to decision makers, because they often thought, well, a model is the truth. And to convey the message that a model isn't the truth, it's perhaps a truth. or an approximation to a truth, depending on how good the model is built, took some time. And it was also quite tricky because on the one hand, you have to, we had to build the limitations, but on the other hand, we couldn't say, well, a model can't say anything. And we had to educate the decision makers a bit, but after a while it worked better, I have to say, but it took some time. So these are some of the questions where decision-making topics were asked and where models were built. The first one is perhaps one of the best examples, that one and the last one that I will show, because here it was very clear that at the beginning we will not have enough vaccines for everybody to be vaccinated. So it was very critical to define who should be vaccinated, and to define these groups according to the risk for the single person, but also to the impact totally for public health. And here the modeling helped greatly in terms of looking which should the vaccination of which groups would ensure the biggest impact at the beginning. And in principle, it was an age prioritized vaccine rollout with a few groups, healthcare workers, for instance, be among the priority groups as well. But in principle, it was an age priority. And the good thing was that although some countries had the age groups and the healthcare workers in a bit different ranking, but these were all in the high priority groups in all over Europe, which helped also a bit for the credibility of this vaccine rollout. Because that is something that we already by that time we knew very well, that when you have divergencies, then it's always questions. And the COVID-19 vaccines had to deal with a lot of skepticism and hesitancy anyway. So it was important that at least the approach to this first vaccinations was very, very, as homogeneous as possible. But also the impact of specific variants, to see what with the models they could anticipate the impacts when you factored in variations of transmissibility and severity. Because at the beginning, it wasn't so well known. What does it mean in terms of hospitalizations, in terms of deaths, in terms of transmissibility, but also in terms of vaccine effectiveness. And that is the last one the last example that I have, and that is from last year, where the pandemic was already subsiding, and it wasn't about necessarily vaccinating the whole population, but more who should be vaccinated now for best effect. And the best effect that we were looking for was really the hospitalizations. They should be minimized. And here you see again, it was a work with scenarios, and it was divided by age groups. The scenarios were divided by age groups, and in the lower part, it is an autumn vaccination plus a spring vaccination for the very old ones, whereas in the upper part, it's only the autumn vaccination. And then you can see to the bars for the colors is the high uptake and low uptake, but the bars show how much the reduction in hospitalization was depending on the scenario. And there it was also clear that whether you vaccinate the 50 plus in addition to 60 plus, that doesn't make so much difference. It made a difference, but not so much. And you had to balance this with the effort that you had, the extra effort that you had to put in. So there was never, a question that 50-year-olds couldn't receive a vaccine. It was more from a public health perspective and a campaign perspective. Where do you put your resources? And where do you put your effort in convincing? Because by that time, thought, oh, we don't need this vaccination anymore. But that showed that indeed you could have an impact on the hospitals, on the strain of the hospitals. So I thought that was a very, very good example for how useful modeling can be built in and factored in public health decision making. Now I have one example that I thought was ingenious, but that countries didn't take up at all. And it's good that Helen is there, because if you have questions to this, then Helen would know what it is, because what I have presented so far went very well with the experts in the countries. But this one did not go well. They basically didn't very much accept it. And I thought it's such a nice tool. It came up in at the time when countries wanted to lift their non-pharmaceutical interventions, and they were wondering what does it mean for the epidemiology. So I think Helen and colleagues constructed this dashboard where the member states could themselves play in their situation. You see here is that the current measures, and then they could take off them, and they would see what kind of impact it would have on their epidemiology, on the increase of their cases. Now we had with the Joint Research Center a so-called response measure database, where we diligently over the time collected which country had which measures from when to when, and that database was used for this dashboard. So it was as accurate as it could have been. And the was of course limited to the early phase, because later too many factors played a role that it was I think it was would have been too complicated. But even at that stage, I do not many countries, if anyone at all, really used that. The problem was also, of course, that these measures were not used as a single measure. They were usually used as a bundle. So from one measure to see the impact of one measure for the epidemiology was also very, very difficult to assess. And I don't know, maybe Helen can explain how this, if it's of interest, how this was done. I just wanted to show this as an example, because I thought we should have explored more with the countries whether they need this before we embark this. But we have translated their wishes into this. I think it's a nice, I thought it was really ingenious, but they didn't buy it. So coming closer to the conclusion, you see here all the areas for our amended mandate. And what you see is that modeling, anticipation, and scenario development is now firmly embedded in our mandate. So it's our legal task, which also means that we will continue with this. Where do I see the outlook with a little bit conclusions and outlook? So the mathematical modeling has significantly contributed to the risk assessments and policy discussions. As I said, at the beginning, there were, I think, just exaggerated expectations from the decision makers, what modeling can do. And we had to sort of bring them back a bit to reality, which I think over time we managed. Also by showing, because often these models, the projections and so forth, are taken retrospectively. When you know how the development went, and then they were looked at, how did they say it would be, and we were very often quite close to how it really happened. That of course also builds the confidence in these models. As I said, it's firmly anchored in the amended mandate. We are now on a have a good basis for continuing. Collaboration is key. We learned that, and we have ever since built on this to increase the quality of the outputs, but also to have platforms for sharing best practices, not only within the EU, but also globally. And that, I think, is one of the marvelous examples of experts around the world coming together and working for one purpose, in a way that it has, how should I say, a standardized approach, but still is adaptable to the regional contexts. That has also the advantage that when these colleagues come together, they know why they differ in their models. And so this public noise around diverging models is reduced because it can already be explained and is not played against each other, as we have seen at the beginning in some cases. So I think that's absolutely necessary. And when I think what we can add, it's the health economic part, because that is in particular in public health where you have interventions that cost resources for prevention often, but also for control. And then sometimes politicians just see the cost of all of this. And there it is very good to say, well, but if you invest that, you save a lot more, double, 3 times as much. And that, if we can say this, it's much better. Some of the proposed interventions can be sold much easier to health ministers, but even more to finance ministers. And that is very important because that's the language they understand. That's when we tell them what they say. Not all the interventions are equally suitable, and not for all the interventions it's easy to find ways how to tease out what the savings could be. But I think that would be an area where it could be further developed and complemented. Okay, now if you want to know what questions models also can be used for, I came across the following headline when preparing for this, and that is mathematical models reveal how a pit viper is able to find its dinner in the dead of night. You can read this. It's a very respectable journal, the Proceedings of the National Academy of Science. You can read their study. I haven't fully understood it. It's about temperature differences of millikelvin, and you can read it, but it's an interesting application, I thought, for modeling. Thank you.
Thank you very much, Andrea. I will certainly be having a look at this paper. Thanks for sharing. That was a very nice overview of some of the modeling work done by the ECDC modeling team here. You also mentioned some challenges, the need to quickly build up modeling capacity, managing expectations from stakeholders, large uncertainties. It was a new disease. Then we had new variants. There were uncertainties about the different, the effectiveness of different NPIs and so on. You touched on communicating with decision makers, very, very interesting. Closing with what's ahead of us, what was missing, this idea of adding dollar signs to what we do and how impactful that could be. Yeah, very, very insightful talk. Thank you for that. We now have some time for questions. So raise your hand or put your questions in the chat. We do encourage everyone to participate. Maybe I can kick us off with one question, which refers to the first challenge that you mentioned, this need to build capacity very quickly during the response. And I was thinking mathematical modeling has long been part of infectious disease control. So we can go back 20 years and think of, for example, foot and mouth disease in the UK, 2001, and mathematical models were at the center of decision making in that outbreak response, not without controversies. However, the preeminence and urgency of modeling during the COVID-19 response seemed somewhat unprecedented. And as you said, the expectations of decision makers were very, very high from with regards to what models can do and all that. And many organizations. So at that time, I was working in Australia, and it was the same case. You know, we went from no modelers to building modeling teams from scratch. So what do you think caused this shift? What changed?
I think one of the main aspects was that the uncertainty of how things would develop and how what would happen. And I think that is also, I didn't go now into this. One of the areas where models can help when you do not know exactly which way it might go. Because when you know, you don't need a model. You just you know how it goes. And that was a situation with really a lot of uncertainty. I mean, in any and every aspect of infectious diseases, at the beginning, we were unclear. And I get until today questions. At the beginning, ECDC was slow to recognize how serious it was. Yeah, well, there were, you know, if you look with today's knowledge to January 2020, yeah, of course you would say, well, how could you say that? But based on the knowledge that we had at the time, that was what we could say. And it just showed us also in terms of the transmission, but also in terms of the severity. We weren't very much aware of the severity. So I think this is where models had their had their chance and they took it.
Wonderful, thanks for that. We have a hand up from René.
Yeah, hello. Hi, Andrea. This is really wonderful, you speaking here to us about the modeling ECDC. Thank you so much. So you will very soon leave ECDC. And when you first arrived, when you came to Sweden, you had a vision, I'm sure. You had a vision for, especially for surveillance, for data synthesis, and how data synthesis supports evidence advice. And I'm sure this vision has changed over time, but it has also led to big things like the TESI collection that we're very much using in the modeling, for example. And I would like to ask you, as you're leaving, there must be many things of that vision that has become true, and many things and parts that have not become true and not been fulfilled. And I would like to ask you about the second bit. So the things that you would have loved to see at ECDC, and you didn't. Yeah, thank you, Andrea.
Yeah, you know that I came to ECDC as head of surveillance, and the task was to build up a European surveillance system. And so until then, surveillance was done in different projects, financed for a certain period of time by the Commission. And there were basically 17 different networks. And my task was to put them together, which I didn't like, of course. So that was the idea at the beginning. So one core element of my idea when I came to ECDC was all data for infectious diseases have to be in one database. There were people that doubted that this is possible. But I said, well, I know it's possible, so we do that. But what I had as a I don't want to say ultimate vision, but as a further idea was that at the end of my work, each member state had a button that says report to ECDC, and that they push this button, and then automatically all the updated data for as far as we had agreed for surveillance were automatically be pushed to ECDC. That was my idea in 2005. That has not come true yet. So we're working still on this in terms of now with the electronic health records and the digitalization. I see a better chance of doing this. But that was my idea at that time already.
Thank you, Andrea. Yeah, lots achieved, and yeah, still things to work on. We have another hand up. Nikki, do you want to take the floor?
Yes, hello. I hope you can hear me.
Yes.
Thank you very much for your talk. It was very interesting, and I want to follow up on René's question. What we could learn, also what you would tell us what we could do better in the future. You showed this example, which was not working that well. And you took Austria, and so I have to take this because I'm from Austria, and we were very much involved in the Austrian computation of these things. My question is it possible, and I think would that be a great idea? We have also some experience with modeling together with the ECDC, and of course we have to make the results comparable. We have to take data which is available everywhere. And this is very divergent, very heterogeneous. Maybe it could be an improvement of such tools to increase the cooperation, as complicated as it is, with the member states of the ECDC. So to go into more detail in the models for the different countries, but still have to try to make it comparable and to keep it comparable in the future. So what is your vision on cooperation of the ECDC with the different countries and with their advantages and disadvantages? Thank you.
I definitely believe for ECDC in the future, we have to intensify our dialogue with the member states and the cooperation. But also, and that has been highlighted already as one of the advantages of our work, to facilitate the dialogue of the member states between each other, not only with us, but also between each other. So because, as I said, I mean, every country has something that other countries could learn from. And that is important to be shared, because then I think everybody learns faster if not everybody has to start from scratch. So the idea is, of course, when we talk about the traditional data, the traditional notification data, to see how far, with all the diversity in health systems that we have, we can, by applying agreed standards, come to more comparability. And then there is the whole world of other data out there that have been collected not for our purpose, but for way other purposes that we also could use. And there again, I think we have to have agreed approaches how to deal with their diversity and with gaps that they have, with biases that they have, and how to take this into account. And I think it needs to be a collaborative effort, definitely.
Thank you.
Thank you, Andrea. We have a comment on the chat from Helen Johnson. My brother worked on foot math modeling in 2001. That's how I was inspired to join the field. I'm a vet, so I followed the 2001 outbreak closely. We have another question from probably Kat.
I think Helen has her hand up as well. Yeah. Okay, but no. Katerina was first.
Hello, my name's Katrina Shea. Can you hear me?
Yeah.
Yes. Hi, I'm on the coordination team of the US Scenario Modeling Hub that we helped in the inception of the EU Hub, and then the EU Hub helped us modify our approaches, and it was a very fruitful collaboration. So I'm originally British and currently function in the US, so I'm more American by academic training. But what I'm really interested in is your thoughts on the following hypothesis. Imagine we went back to the beginning of 2020, but with all the knowledge we have now. It seems really obvious to me that there would be a very strong impetus for a 2-week to maybe a month lockdown globally, which could have nipped the entire pandemic in the bud. But anything like, I'm just, waving my hands at that idea, but anything like that requires massive amount of coordination all across the planet, not just within the EU or just within the US, or even just US-EU interactions. And I wondered, in your experience at the head of ECDC, what links do you have with the wider global health community that would allow something very massive in terms of a response to take place in the event of a future obvious pandemic looming?
Okay, so there are two elements. One is the links to the wider public health community that we have now after the pandemic even further expanded. So before the pandemic, we had collaboration agreements and working relationships with the US CDC, with the China CDC, with Public Health Canada. Now we have even more. We have Australia, South Korea, Japan, Mexico, Brazil. So it's much broader even. Now the other thing is, as helpful as these regular meetings, I think we met or we called for telephone conferences once a month, and it was very helpful. Although different parts of the world were at one point in time at different stages of the pandemic. And this is why I don't think a global lockdown would help, because for some countries it may not even be relevant at that stage, and then politically very difficult, because that is the other point, that these partners that we have have very different influence politically. And basically, I don't want to say zero, but not much. When it comes to really these measures, we, for instance, we have no to do risk management at all. We can't tell the countries you have to do this now. We can say, well, these are your options. Now we can even give recommendations, but they're still non-binding because the countries decide about the risk management, the measures to take themselves. And that, I think, is sort of the little how should I say, crink in the plan? Well, the one thing where it probably won't work. However, what it did help to is that we could exchange what is it that underpins our opinions, so that the advocacy is at least streamlined and saying very much the same, so that it's more or less taken out of the equation that say, yeah, but there in Europe they do it like this. The US CDC says like this. So that is something that we can do at our level to standardize the advice and the guidance in a way that there these little differences can be used as leverage.
Thank you, Andrea. Very insightful answer. We may have time for a very short question and answer. Helen?
Thank you very much. And it was actually sort of more of a comment on both of the past two things, really, which is that I think what modelling can do is it can get to the essence of why different contexts are the same and why they're different and why it matters. So it lets you get behind and understand what drives the similarities and differences between the way things that play out. And I think that's an amazing thing that ECDC can do, because you've got a population of roughly 550 million people in a diverse context. That's a great opportunity to learn about why things play out the way they do, and how different interventions can help or not. And I think that's even more exciting, personally, when you look more broadly at work with the other CDCs and so forth. So I think just a super opportunity, and it's a great pleasure for me, actually, thinking back to 2017 to think how far this has all come. So yeah, thank you very much.
Yeah, thank you, Helen. And just to say, we are not 550 anymore.
Well, populations are growing all the time, even when some leave. Yeah.
Yeah.
Okay, fair enough. 500. I'm counting.
Yeah. Okay.
Right, 2 minutes to close. Andrea, do you want to tell us very briefly what your plans are after retirement?
Well, I will definitely, after 37 years, stop with the infectious diseases.
Mm-hmm.
And what I will be doing, you have to wait for the 13th of June.
All right, fair enough.
I will tell you.
Well, thank you very, very much, Andrea, for your time.
It was my pleasure.
Yeah, it was lovely to have you. And thank you, everyone of you attending today's session. Have a nice rest of the day and see you next time.
Bye-bye.
Bye-bye. Thank you so much.